I want to give you a warm welcome to this conference that is hosted by the Department of Equity, Ethics and Policy at the University of at McGill University and the School of Population and Global Health. So today we will start with an opening keynote. We're bridging the past look that we had yesterday at the Lalonde legacy, and we are moving today to look at the future and look at some potential for changing things, moving the needle, because we did, I think, the verdict from yesterday was that there is still a lot to do to move the needle towards equity, and we will hear more this morning today about where that might take us. Wicked problems and emerging issues will follow. Then we will have a panel on what will it take, and you'll hear policy pitches and react to those policy pitches. And then we'll have a closing keynote on innovations in public health. So without further ado, I will turn to the opening keynote, and we first have the pleasure of welcoming a very distinguished guest as our moderator. So Professor John Frank is a highly accomplished academic with a background in medicine, community medicine, family medicine, and epidemiology, lots of medicine there. He has held some prominent roles, such as professor at the University of Toronto, founding director of research at the Institute for Work and Health in Toronto, and importantly, for this particular moment, inaugural scientific director of the Canadian Institutes of Health Research, Institute of Population in Public Health. And so, and John is also a member of the SPGH International Advisory Board. And so when I saw the connections, and with having Dr. Frohlich here to give the opening keynote for today, I thought, what better way to connect the arc of having the inaugural as the scientific director of the IPPH, introduce the current director of the IPPH 24 years after the creation of the CIHR. So on that, John, I will leave the floor to you. Thank you very much for joining us today.
Merci Amélie. Bonjour à tous. Je suis ravi d'être ici. Malheureusement, mon français, c'est pas bon ces jours-ci, parce que je demeure en Écosse depuis 16 ans, et il n'y a pas d'opportunité en Écosse pour parler français. I also didn't bring my kilt. Yeah. Because I'm not Scottish, of course. I'm Canadian. Yeah. I'm really delighted to introduce Kate, and I mean, you can read in her bio her many, many accomplishments, but I want to make it a bit more personal, this introduction, which was I was fortunate to teach her at Berkeley on her postdoc in a mere 24 years ago. And there I became aware of her tremendous capacity for deeply critical thinking about, well, certainly most of what's written in public health journals and books. She's a deeply critical thinker, and she integrates social science perspectives with epidemiological and other perspectives in a way that few people do. And so I was completely thrilled to hear that she'd been appointed as of September as the new director of CIHR IPPH. You know, I can just say this about Kate. We were reminiscing about what a good experience we had. I was just at Berkeley for a few years, but I was there partly to learn how a school of public health works, a good school of public health, although a small one by American standards, 50 faculty really. And what I think both of us learned there was that Canada was really missing something. It did not really have a proper school of public health. The University of Toronto, where I was, would claim they had one, but I'm going to tell you, tain't so. It didn't have that vision. Now it does, and I think it has good vision, and it has a wide reach. And that struggle has also been a long one for other universities. And you know, the University of Montreal has done very well. McGill's now, I think, come up to the mark. We have a school of global and public health, population health here. And I think it's been a very slow struggle, partly, I'm going to say this out loud, because the federal infrastructures for health in Canada are still not what they could be when it comes to supporting research. And if you compare what American schools of public health get in the way of research and training funds from CDC Atlanta and various other federal agencies, you would immediately see there's something missing in Canada, and that has never been rectified. So I'll stop holding forth, and Mesdames, Messieurs, je vous donne Katherine Frohlich.
Merci beaucoup, John. Je ne peux pas vous dire à quel point je suis ravie aujourd'hui de pouvoir et excitée que cet événement ait lieu. Depuis le début de mon mandat de directrice scientifique à l'ISPP, je me suis rendu compte que 2024 était le 50e anniversaire de ce rapport Lalonde. J'ai rapidement commencé à contacter de nombreux partenaires de l'ISPP à travers le pays pour leur demander s'ils avaient l'intention de célébrer cette étape importante. La réaction de tous a été un enthousiasme débridé. Mais c'est le DIP, sous la direction d'Amélie Quesnel-Vallée, que vous vous êtes mis au défi et que cette célébration devienne une réalité. Merci beaucoup, Amélie et tout le comité. Ça a été une très belle journée hier et ça va l'être aujourd'hui. Je tiens à vous remercier de votre vision et d'avoir créé le forum pour célébrer le 50 ans de Lalonde. On a more personal note, and actually, John, you kind of stole my thunder. We're going to say exactly the same thing. So we actually were in the same place at the same time, doing the same things. It's just so incredibly special for me to be introduced by the inaugural scientific director of the Institute of Population and Public Health, John Frank. John took me under his wing, as he said, when we were both together in Berkeley, California from 2000 to 2002, when he was at UC Berkeley as a visiting scholar and me as a postdoctoral fellow. He's been an inspiration to me from then and obviously continues to be one as I take on the reins of IPPH from where he started. So, pour aider les interprètes, je ne basculerai pas entre le français et l'anglais pendant ma présentation, mais ferai plutôt ma présentation en anglais. Il me ferait cependant plaisir pour les francophones dans la salle ou en ligne de répondre aux questions en français, donc n'hésitez surtout pas. So I'd like to begin by quoting the enticing poster that the Lalonde 50 organizers put together. On it, they asked the following: how can we move the needle on equitable health promotion? Their goal, again, as stated on the poster, is to discuss the history and legacy of Marc Lalonde's groundbreaking report and to critically assess how far we've come in building a society that produces health, not sickness. In the next 30 minutes or so, I'd like to start with, or share with you my vision of where we've come in health promotion and public health more generally since Lalonde. I intend to share with you the arc that I see between Lalonde, 50 years ago, and one of the new strategic initiatives at the Institute of Population and Public Health that we have called Moving Upstream, that my team and I have been working on since I began my mandate. I would argue that the goal of moving upstream could help us move the needle on equitable health promotion, moving forwards in research, policy, and practice in Canada. And of course, yesterday, you beautifully set us up, the historians, to set the stage for what Lalonde did and some of the legacy. And now I'm going to try to move us a little bit further. So we went over some of this yesterday, but not all of it, but I'll give it slightly different perspective as it's coming from public health. The Lalonde report was innovative in a number of ways. I'm going to focus in particularly on two innovations that were critical for my own understanding of where this report had the most impact on public health at the time and where it set the course for public health today. I'm going to quote directly from the Lalonde report, as there's nothing better than going to the source. Lalonde writes, and I quote, "The health field can be broken up into four broad elements: human biology, environment, lifestyle, and healthcare organization." We heard a lot about these yesterday. Don't worry, I'm not going to repeat. These four elements were identified through an examination of the causes and underlying factors of sickness and death in Canada, and from an assessment of the parts the elements play in affecting the level of health in Canada. End quote. Here note that Lalonde is using very early determinants of health language. This is before we talked about the social determinants of health. Lalonde was path-breaking with these simple 4 broad elements in a number of ways. First, and we heard this a little bit yesterday, or actually quite a lot, he put healthcare organization or the healthcare system last in order of importance. This was deliberate. We're in an era of exploding healthcare systems and financial strain. The Liberal government at the time was looking for justifications for cost-cutting in healthcare spending. But the report did not just deprioritize healthcare. It shone the light on other new factors, especially lifestyle and the social environment, hailing a new era of thinking concerning what factors we mortals have some agency over, and others which are, as he calls them, out of our control. Of course, there continues to be significant debate around issues of agencies around lifestyle factors or health behavior, but suffice it to say, Lalonde began this debate officially by placing these factors as being significant in shaping health and disease. And there was some critique yesterday about the Lalonde report being not forward-thinking enough, but at the time, we do have to remember, this was path-breaking to think of the determinants of health in this way. Very important from a historical point of view. I would argue indeed that our thinking about how out of individual control these lifestyle and environmental factors are has shifted considerably over the past 50 years, paving the path for us in 2024 to begin serious engagement within the public health research, practice, and policy realms around the structural determinants of health, also previously believed to be somewhat out of our control. Second, in line with the major cardiovascular disease intervention trials that actually George Weiss gave a nod to yesterday, that were the major innovations in public health at the time, COMET, Pawtucket, Mr. Fit, North Karelia, and Framingham and others, the Lalonde report paved the way for new ways to build policy for prevention. Public health interventions needed to focus attention away from just diminishing incidence and prevalence of particular diseases, but rather our attention should be turned to the segments of the population with the highest risk, but the highest level of risk exposure for the major causes of illness and disease, indicated from health-related risk behaviors at this time, in particular for cardiovascular disease. There were other chronic diseases, but in particular he focused a lot on cardiovascular. These he called populations at risk. These populations, he argued, because of their high-risk profiles, contributed the most to the average risk and thus required the most attention. The justification for focusing on these populations at risk resulted from 3 kinds of information: the causes of mortality and kinds of morbidity, the underlying reasons for their occurrence, and the susceptible segment of the population, those who exhibited the risk factors. I think we spoke to this yesterday. At the time, these were considered older white men. So coming back to the gendered part of the discussion yesterday. So for those of us who are fans of the normal curve, essentially the idea behind a populations at risk approach is that interventions that seek to reduce morbidity and mortality for any particular disease should focus on those people on the extreme right of the risk distribution. So this is the colorful part of the slide. In order to shift those who are at high risk into an area of being at lower risk. So a big focus at those who were engaging in the high-risk behaviors that were leading to the chronic diseases at the time. So at the time that I was at Berkeley, I had the chance of spending, actually I was there studying with Dr. Leonard Syme, who taught me, amongst other things, about his deep thinking and reflections around the Mr. Fit. From years of experience with populations at risk approaches, scholars such as Dr. Syme, one of the original scholars behind the multiple risk factor intervention trial, or the Mr. Fit, suggested that even if populations at risk approaches worked, and we now know after years of failed or largely moderately successful large-scale risk factor intervention trials, those who are about to become at risk replace those who have been cured. And why? Well, Syme argued that the population at risk approach, while focusing on those most at risk, fails to focus on the upstream or population level causes that led the high-risk groups to become high risk in the first place. He argued and cogently that unless we focus on the causes leading to high-risk behaviors, so here in the middle, most people would simply replace those at high risk over time. And of course, we all know that this began with Lalonde's critique and then with Lalonde and then Syme's critiques and critiques of others, many years of criticism about the populations at risk approach with its overemphasis on lifestyle that was beautifully covered by Catherine Carstairs yesterday, the stigmatization of populations and others. But again, just to be clear, this was not Lalonde's intent, and this is only on reflection years later that this came about. So meanwhile, across the pond, Fast forward some 12 years to 1986. WHO Europe organizes its conference in Ottawa, and the result is what we now call the Ottawa Charter for Health Promotion. Unlike the Lalonde report, which focused on a definition of the health field or way of defining what causes health and disease, the Ottawa Charter turned attention to the how of health promotion and public health, the various means that health can be created and improved. So the doing of public health. The Ottawa Charter laid out 5 key action areas in health promotion, or axes. The first, building healthy public policy. Second, creating supportive environments for health. Third, strengthening community action for health. Fourth, developing personal skills. And last but not least, reorienting health services. The Charter also recommended 3 basic health promotion strategies in order to guide change: to enable, mediate, and advocate. Well, for those of us steeped in the health promotion tradition, the Ottawa Charter is a sort of original document. I would maintain that it is too frequently omitted from conversations about where we need to go in public health and how. And actually, there was very little discussion about it yesterday, interestingly. Indeed, I'm going to develop the argument that without the Lalonde report and the Ottawa Charter, we would not have been able to develop ideas around the structural determinants of health. I would draw particular attention to the action area called Building Healthy Public Policy. This area was innovative at the time for moving beyond what had formerly been known as public health policy, which was concerned with health problems based primarily on a biomedical determinants of health model. Healthy public policy, differently from public health policy, was prone in the Ottawa Charter as being concerned with the conditions that create a healthy and just society based on the social determinants of health model, which had been created between Lalonde and the Ottawa Charter. This axis was clearly the predecessor to what we now call health in all policies, and which you will see undergirds our new strategic initiative, Moving Upstream. Meanwhile, across the pond in the UK in 1994, Geoffrey Rose, the originator of the infamous Whitehall study and postdoctoral supervisor of Sir Michael Marmot, to whom he bequeathed Whitehall, published The Strategy of Preventive Medicine, which, if you haven't read it, by the way, please do. It is also an original document, which in my mind is a deep critique of the population at risk idea that is at the basis of Lalonde's report. Rose also builds on Syme's critique of Mr. Fit without intervening on those left exposed to whatever had made those who were most at risk, more people would just enter the high-risk population, somewhat like Sisyphus. At the core of this seminal book is the refutation that intervention should focus on those members of the population most at risk. Rose cogently argues that one needs to focus on shifting the entire curve to the left, as health is a group phenomenon, not simply one of individuals. So I want to walk us just very quickly through his 4 principles, because they're really fundamental to many of the arguments made since, and is at the very basis of our new strategic initiative. So the first of these principles we find is in his incredible treatise, The Strategy of Preventive Medicine, is that the causes of cases are not the same as the causes of incidents. Harking back, actually, to Lalonde, there are environmental factors affecting causes of incidence or differences between population levels of risk that are as worthy of study and intervention as causes of cases, which tends to be the focus of clinical inquiry. Secondly, he argues that the majority of cases occur in individuals at average risk, so in the middle of that normal curve. Here, Rose leans on the normal curve and the fact that most phenomena in humans are normally distributed. So if you follow Rose and Syme's critique of the population at risk approach, those in the middle of the population are actually the most numerous. So they participate in very large numbers to being at risk for many of the health problems and behaviors that we are concerned with. So not taking into account those in the middle is missing the mark. Thirdly, the aim is to improve the condition of the overall population by modifying the conditions that shape the distribution of risk. Unlike Lalonde, here Rose suggests that we need what became known as the population approach. This approach, rather than focusing on those most at risk, would focus on ways to shift the entire normal curve to the left by diminishing population risk profiles as populations move together with their health behaviors, morbidity and mortality. The classic examples, many of which we discussed yesterday, of these population level interventions are, of course, seatbelt laws, the fluoridation of water, anti-smoking laws in public places, and universal vaccination, just to name a few. And lastly, for those of us still clinging to those the most at risk, by changing the conditions that affect the overall distribution in the population, one also improves the risk of those most at risk. So this is essentially what it looks like from a Rosian perspective. So this is a recap of, unlike Lalonde, who put the focus on that right-hand side of the normal curve in diminishing the risk profiles of those on the right-hand side, Rose's theory of population change turned attention to the population factors that could be acted on to shift, as you see in this slide, the risk profiles of the entire population to the left, thus shifting those most at risk to the left as well as the rest of the population. This population approach is consummate with utilitarian notions of justice, better known by the edict, the greatest good for the greatest number. And there has been quite a bit of critique around this, which I'm happy to discuss later. So there have been critiques and other developments beyond the population approach, obviously, since 1994, including my own, written up with Dr. Louise Potvin in the American Journal of Public Health in 2008, where we argue that population approaches may unintentionally lead to inequities in health, as not all population members are able to respond equally to population-level interventions. Numerous other public health scholars have taken these arguments and others to important places and developed intervention ideas, such as proportional universalism, as ways of tackling both population-based problems and potentially inequities in health. I invite all of us concerned with equitable health promotion to engage with these issues, as they're at the core of where we need to go in thinking about how to intervene and overcome inequities in health. This is for you, John. So I'd be remiss to omit mention of the following book. Again, another that should be read by all of us in public health, Why Are Some People and Others Not?, which brought together as authors some of the top researchers at the time working in and around the burgeoning field of population health here in Canada. From my perspective, the work in this book is the origin of the name of the Institute of Population and Public Health. What this book argued was the importance of thinking comparatively about health inequities and moving beyond healthcare as the main determinant of health to the social determinants of health and ways of shaping these, thoroughly in line with Lalonde, but bringing it, of course, several steps forward. In preparation for this talk, I looked up a review of the book by Dr. Vivek Goel from the University of Toronto, who wrote in the Canadian Medical Association Journal in 1995 the following. I hear John chuckling. The group can be largely credited with placing the concept of population health in the minds of health policy makers in most of the country. Each of the major chapters focuses on a different determinant of health and has a different author, often from a different disciplinary vantage point. Although the authors have done an admirable job of bringing together the concepts of population health in one book, they have raised even more questions In an era where social programs and healthcare compete for diminishing resources, we need to know where to direct funds. Strong evidence of the failings of the traditional medical care model is presented, and it's difficult to dispute the role of broader factors in determining health. However, it's unclear whether there are interventions to address them, let alone whether these would be effective." End quote. Clearly, this important book, which played a pivotal role in shaping the future of equitable health promotion in Canada, left us with some homework to do. Fast forward now some 10 plus years. The same Michael Marmot, doctoral student of Leonard Syme, postdoctoral fellow of Jeffrey Rose, becomes the chair of the WHO Commission on the Social Determinants of Health, CSDH. We heard a little bit about this yesterday. This commission was established to support countries and global health partners to address the social factors leading to ill health and inequities. It drew the attention of society to the social determinants of health that are known to be among the worst causes of poor health and inequalities between and within countries. The 2008 report that resulted from this commission yielded 3 overarching recommendations that I thought would be really helpful to share today. The first was to improve daily living conditions, extremely broad. The second, to tackle the inequitable distribution of power, money, and resources. The third, to measure and understand the problem and assess the impact of action. This was the first report of its global status to explicitly call out the unequal distribution of power, money, and resources as key system drivers that maintain health inequity. Moreover, they named this as a political endeavor, harking back in interesting ways to Rudolf Virchow, the influential German pathologist and politician from the 19th century, who's most famously quoted for saying the following: "Medicine is a social science, and politics is nothing more than medicine on a grand scale. Perhaps we can just shift medicine for public health." End quote. The report was importantly drew the direct link in inequities in conditions of people's lives, their access to health care, schools, and education, and housing, and their chances to reach their full health potential. This distinctly intersectoral approach to overcoming inequities opened up new potential for thinking about theories, methods, approaches, and policies to tackle health inequities. So, as part of the CSDH's work, a framework was commissioned to undergird the report. This framework that you see on the screen thus became the go-to for those of us working in health inequities and equitable health promotion spaces. And we saw it again yesterday in the presentation of Dr. Mylène Drouin. I'm going to walk us through this framework, though, not as some sort of educational exercise, as I presume almost everyone here has seen it, maybe over and over again, but to explore together our collective shortcomings in understanding and acting on it. So, on the far right-hand side, you see the outcomes that most of us are concerned about: inequities in health and well-being. The fact that some groups of people are able to live with less morbidity and longer than others. One box over are the intermediary determinants of health, or what is often called the proximal determinants of health. These are the conditions that are needed to be healthy. Solar and Irwin, the authors of this framework, break these down into 3 categories: material circumstances, behavioral and biological factors, and psychosocial factors. These categories are reminiscent, of course, of the categorizations put forward through the Black Report, commissioned by the Labour government in the 1970s and, as said yesterday, shelved by the Thatcher government, which then made it even more famous. Essentially, what this box suggests is that a combination of good material conditions, good health-related behaviors, and good psychosocial conditions are all necessary to make one and populations healthy. One further block over to the left are 2 pillars, one delineating what are called the social determinants of health, and the other further to the left, what are called the structural determinants of health. These social determinants are the broad categories of determinants that create inequities in the ability to obtain and profit from the intermediary determinants of health, So, for instance, we know now from decades of research that socioeconomic position structures one's ability to profit from safe, healthy housing, good quality food, and one's ability to engage in health-producing behaviors. It's not just choices. The same is, of course, true for all the other social determinants, such as gender, social class, ethnicity, education, occupation, and income that you see on the screen. All of these social determinants structure individual and population's ability to profit from the circumstances that produce health. What is less well known, however, is how the structural determinants shape these more downstream social determinants. So I'm going to give an example. It is not set in stone, it's not nature, for white people in North America to be more healthy and die later than black people. Ethnicity or race is not a natural cause for poor health. Black people are only more sick and die earlier than whites because of the structural determinants that create the conditions that make them more sick and die earlier, or what Solar and Irwin call the socioeconomic and political context of health. These contexts are also not natural or immutable. In fact, we create them through our policies and everyday practices. But what if we create them, we can also change them. So why haven't we? When the World Health Organization's Commission on the Social Determinants of Health published their framework for the social determinants of health in 2010, they intentionally distinguished between the mechanisms by which social hierarchies are created and the conditions of daily life, which then result. WHO continues to include both the conditions in which people are born, grow, live, and age, and the wider set of forces and systems shaping the conditions of daily life in their definition. Yet almost immediately after being published, many simplified the social determinants of health concept to include only the conditions of daily life, or what you see on the screen in the intermediary determinants of health. For example, as part of Healthy People 2020, released in 2010, the US Centers for Disease Control and Prevention referenced the CSDH, but defined the social determinants of health as only the conditions in the environments in which people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks, end quote. As others have critiqued, this depoliticizes the concept of the social determinants of health and is perhaps a result of dominant neoliberal worldviews in the US and elsewhere. Indigenous scholars and practitioners extend that critique with a focus on the importance of decolonization, sovereignty, and self-determination as key social determinants of their health. The critique was catapulted forward with the Truth and Reconciliation Report here in Canada. Concurrently, a new wave of attention to racial and health inequities since 2020 and the murder of George Floyd by policemen in Minneapolis, public health researchers, practitioners, and funders have recognized that a focus on social determinants alone is insufficient and have highlighted the need to focus on the structural factors, those closer to the root of inequities and solutions. Now it's going to be slow. Should I try this? Maybe that'll be faster. Thank you. So I find that I get increasing pushback when I present the 2008 WHO model. I don't know if the rest of you feel the same way. It's a little out of date, missing important determinants, as important as it is. Happily, yesterday, Dr. Carolyn Bennett introduced the tree model. So here's another one, based on the social determinants from a closer to home recent report by Dr. Charlotte Lopi and colleagues, which explores the determinants that shaped diverse Indigenous peoples' health through a social determinants model. This model uses the tree metaphor, grounded in the natural world and Indigenous ways of knowing that are distinction-based, land and water-based. The roots of the tree represent the structural determinants, deep ideological and political foundations that define health equity and societal wellness and shape all other determinants. The trunk, or the core determinants, represent community infrastructure and systems, and the STEM determinants have a more immediate impact on individuals' health, like health activities, behaviors, and food security. So I submit to you that we have work to do to achieve equitable health promotion. On the screen, I just needed to share some data. I am an epidemiologist, public health specialist, but these speak to some important challenges that we have. This is recent Canadian data showing once more that we've failed to address social inequities in health. In this first example are trends in inequalities in premature mortality by income quintile in Canada from 1991 to 2016, stratified by gender. The colored lines represent the relative risks of dying prematurely in relation to the wealthiest Canadians over time. The findings are striking. Not only are the inequities significant at all time points, but they increase over time, while our country has become, on the whole, wealthier, and more power and wealth has accrued amongst the wealthiest among us. If we just look at the blue line for men, this tells us that men are 2 times more at risk of dying prematurely than the most wealthy, because that the poorer men are 2 times more at risk of dying prematurely than the most wealthy between 91 and 96. Not only this, but their risk increases over time in relation to the wealthiest, rising to almost 3 times by 2016. This is not, again, natural or normal. This is mutable through policy. And then perhaps even more damning recent evidence based on inequities in neighborhood income. Here we see COVID-19 related deaths disproportionate to neighborhood income in Ontario across 7 waves of the pandemic. All neighborhoods in Ontario seemingly were equal at the beginning of the pandemic with regard to COVID, but this equity was chipped away as the pandemic marched forward, with the neighborhoods of lowest income, the purple line of the top, experiencing almost 3 times more cumulative deaths than those living in neighborhoods with the highest incomes. And I would submit to you that in order to do an equitable health promotion, we need to focus not just on what happened to those at the bottom, but why those at the top were able to stay healthy. This is incredibly important in learnings from health promotion, that we need to better understand not only what makes those at the bottom less well, but what makes those at the top better off. So, thus our new strategic initiative at the Institute of Population and Public Health, entitled Moving Upstream. I think we've done quite well in health promotion, social epidemiology, and public health in general on the side of what some call the science of problems. We're extremely good at demonstrating that social inequalities in health exist. Over and over again, across social determinants, we demonstrate that there are inequities in morbidity and mortality for a wide variety of diseases and risk factors, and I've just showed you 2 of them. What we're less good at thinking through and demonstrating is what we can actually do to reduce these inequities, or to fulsomely engage in what is called the science of solutions. So what can we do differently? Well, first, clearly, there's need for more and different types of interdisciplinary work. These upstream questions are not just for epidemiologists or health promotion experts alone. We need to work alongside political scientists, economists, policy experts, anthropologists, urban planners, and the list goes on. The announcement in the Canadian Budget 2024 that a new capstone organization will be created to oversee the Tri-Council federal funding agencies, namely CIHR, SSHRC, and NSERC, opens up new interagency collaboration possibilities that may enable scholars this kind of work. The time is ripe. So, now more than ever, we need to think intersectorally. We know that health promotion and public health needs to work more hand in hand with organizations, both public, private, and nonprofit, who work in spaces that do not fall directly into public health organizations working outside of questions of the outside of public health, questions of the environment, education, law, etc. And we saw this very cogently in the presentation by Dr. Drouin yesterday. And the science of solutions can come about in changes at every level, given that health is produced in the home, in the neighborhood, city, province, country, and world. The drivers of health are potentially different at these various levels, but they certainly exist, and to quote myself, are mutable. Le monde des possibles is large. Years of health and all policy experiments need to be honed and moved forward. What my colleague, Dr. Ditte Hering-Holt, assistant professor at the University of Southern Denmark, and I have called health equity in all policies. So, the overarching goal for those of you hungry to do research in this area is to come up with a new area of research, policy, and practice investment at the Institute of Population and Public Health, which has as its goal to nurture a robust range of interdisciplinary research approaches that seek to understand the way structural determinants create, maintain, and exacerbate health inequities in Canada. I'll walk us very quickly through the various objectives of our new area of investment. There are 3 consecutive objectives. First, to catalyze transformative research to increase the evidence base on the structural determinants of health inequities in Canada. Second, to support a range of identifiable and novel interdisciplinary research designs, theories, methods, and approaches to understand the structural determinants of health and their impacts on health inequities. And third, to foster connections and collaborations between researchers and partners across a broad range of disciplines and support effective knowledge synthesis and implementation. Of course, this new area of investment has been tested out with many of you in the public health community through engagement and collaboration, and I'd like to underscore the tremendous work that we've done with the National Collaborating Centre on the Determinants of Health under the leadership of Claire Betker, through discussions with IPPH's Institute Advisory Board, and pulse-taking that has happened since my mandate began. So here's the way we're looking at it for now in terms of our areas of investment. We have potential research topics, and these are not exclusive, which undergird the ideas behind this new area of investment. So we see that this list includes, for instance, much inspiration from Solar and Irwin's framework, but we go beyond. So work needs to be done on health, public and social policy, governance frameworks, and macroeconomic policies. We add to this structural determinants in new areas of inquiry that are particularly Canadian, we find, around the ecological determinants of health, structural racism as a determinant of health, and commercial determinants of health. While some of this work has already begun among researchers in the CIHR research community and beyond, SSHRC as well, bringing these disparate scholars together under a coherent umbrella of work to support and build capacity is the goal of this. So to close, I moved from being a scientific director to being a saleswoman. And this is going to be my pitch. I actually have 2 pitches. So this is an advertisement here for our brand new Catalyst Grant funding opportunity under the auspices of Moving Upstream, the structural determinants of health. We hope that as many of you as possible will apply, as we brought multiple institute partners on board and have been able to come up with a $4 million investment to launch this new area of research for Canadian researchers. Please do use the QR code to access the information about this funding opportunity or find it on our IPPH webpage. Lastly, please all sign up to be a recipient of our newsletter so that you can be kept abreast and let us know what you think about this funding opportunity and the directions we can take Canadian research in population public health, which includes front and center equitable health promotion. Thank you very much.
Okay, thank you. It's really revealing how much one sees when one goes back over documents one has known and worked with, policies over, in my case, 5 decades. So that was very thought-provoking, and grateful to you for doing that. We're now going to field questions both from online, which we're just waiting for to come up, and from this room. So if you put your hand up, I'll acknowledge you. And there's roving, there's a roving microphone here. Thank you for that. And there's a fixed microphone here, 2 roving microphones. So take any questions from the floor here. Yeah. You guys? Yes, sir. Sure.
What's the role of public medical literacy in achieving the public health goals that you've described? We do have the resources. What do we do with them?
Kate?
Thank you. So, public medical literacy, or what some call health literacy, is certainly in there. There's absolutely no question. I would suggest that it is in that early box of the proximal determinants of health, and that it's shaped by social and structural determinants, but it is a key proximal determinant of health. If we are not able to understand not just our medical information coming in, but for instance, we saw it during COVID, information about how the epidemic or how the pandemic was affecting individuals, populations, understanding why we needed to do the things we had to, we will have real problems, and we saw it in controlling and enabling health in populations.
I just chime in one comment on that briefly, which is that there is, as you know, a fairly large literature now on health literacy, and that seems to have had its deepest roots in the United States, which always makes me worried. And having spent some time with Kate at Berkeley and other periods of study there, I worry that health literacy as a concept suffers from individualization. It situates the problem at the level of the individual and a set of skills. And I can't buy it as a fundamental determinant. It's a useful intermediary determinant, maybe, but I find it to be quintessentially American, like so many other things that have influenced thinking in this area for a long, long time. Yes? Actually, I should get people to introduce themselves just briefly.
Yeah, please.
Yeah? Okay, thank you. Gaynor Watson-Creed, I'm a public health physician and associate dean at Dalhousie University. Just on that point, Dr. Frank, and thank you for going there, I wonder if both you and Dr. Frohlich would comment on this. I too worry about paradigms that come to us from south of the border. For a number of reasons, not only because they're American, but more because I continue to see something that looks maybe even more sinister than reinvention of the wheel when that happens. So as an example, I recently visited an AMA conference on systems change, where I was somewhat perplexed to see that what the AMA was talking about as radical systems change opportunities were the same social accountability and social justice mandates that our medical schools in Canada have had now for decades. And so they gave it a new name, they called it health system science. They have a textbook that they've published on it called health system science. And it has me wonder if we are at risk as we advance these very, very complex and very, very heady topics that you pointed to, Kate. Are we at risk of missing each other in the dialogue? Are we at risk of talking at cross purposes because we are using different language and maybe not even seeing the concepts the same way? And if that's true, then what do we do with that?
Kate?
Wow. Great question. Dr. Watson-Creed, who is, by the way, a member of our advisory board. So it's interesting because when I started thinking about bringing structural determinants of health to IPPH and creating this investment, some wise members of my team said, but haven't we already done this? Are we reinventing the wheel? And we actually decided that we hadn't fulsomely done it. in Canada. So I don't know that I'm going to directly answer your question, but I don't think we have, and I don't think we are reinventing the wheel. I think we're turning a slightly different, deeper lens, thinking through more intersectorally than we have in the past, and adding determinants, structural determinants that were previously not on our radar, into the conversation in ways that they haven't. So I don't know that I've answered your question, but that's my attempt.
Again, I have to make a comment. It's the American Medical Association you're talking about, right? So, you always know an organization by a lot about it from its history. So the AMA is very famous for having fought tooth and nail against national Medicare, public health insurance, universal health coverage in the United States, and ran a campaign, I would think about 25 years ago, maybe 30 years ago, in which they documented unnecessary deaths in Canada from inadequate access to, as yet, I would say, unproven interventions of a very aggressive kind, like massive use of interventional cardiology in acute myocardial infarction, things that are normal in the United States but have been shown to be unrelated to mortality outcomes, even when they vary enormously across small areas due to the availability of interventional cardiologists. So the history of the AMA is the AMA has no interest in universal health coverage, and my experience of it. And yeah, I would say anytime they reinvent something and call it like systems change, I'd be looking for the pony. I'd be asking, like, what are they really on about? What do they really want to accomplish? So forgive my cynicism, but yeah, go ahead. Anybody else? We should walk to online here for any questions.
London School of Hygiene and Tropical Medicine. Thank you so much, Katherine. I think your presentation followed on beautifully from some of the things we were talking about yesterday, and took us away from just thinking about risk factors and individuals and bad behaviors, and thinking about the structural determinants of health. But I guess the obvious question is, when you look at those charts that you showed at the end, which are horrifying but not that surprising, that things have gotten worse. And we've known about this since, as you said, since the 80s, since the 90s at least. I mean, the obvious question is why?
Yeah, political will. So again, this question keeps coming up again and again, thank you. But it's important that we keep asking ourselves this. And indeed, we have now over 30 years of really path-breaking data on the social determinants of health inequities, right? So we know they're there. We know they're getting worse. What do we do about them? We fully believe that if we can show with natural experiments, with more comparative research, that policies, interventions that actually improve health at a population level, and to quote people yesterday, that are cost saving, that there is a good reason to intervene in this way. But we do need more data on the policy implications. And this was very much what was behind the WHO Commission report, and what the call was from Sir Michael Marmot and the other commissioners. So,
thank you.
Go ahead.
Hi. Christabel Sethner from the Institute of Feminist and Gender Studies, University of Ottawa. So you can guess that I live in Ottawa, however reluctantly. And not 10 minutes on foot from Parliament Hill, one can see on the streets homelessness, drug addiction, mental illness, and I think it's shameful in a capital city of an incredibly wealthy nation. Has there been any discussion about universal basic income as a factor in health? Can we see that in the future? And I'm saying this for two reasons. First of all, we already have the data. We have so much data on the relationship between income and health. That's the first reason. And the second reason is the rise of AI which will determine a lot of the way the economy will function and what jobs are available. So it may be that we, or a larger sector of the population will need a basic income, a guaranteed basic income. What are your thoughts on this?
Thank you so much for this thoughtful question. And indeed, so as you and others in the room would know, there was a pilot run in Ontario by some very well-known researchers in the population and public health community that was a pilot to test the effects of universal basic income, and it was shut down by the government. So these are hot topics that are going to be, but we need to create more research opportunities. So these are exactly the kinds of questions that need to be studied, where we need to show the impact on health and health inequities in order to bring them forward as policies. And I would submit to you, indeed, since I'm now going to Ottawa a lot more frequently, I also was shocked to see at how desperate the streets are of Ottawa. It is horrific. But interestingly, I mean, obviously this particular Liberal government is aware. It's not for nothing that housing is at the top of their priority list in Budget 2024. There's some opportunities, hoping the window will be larger rather than smaller, to act on some of these upstream factors through Budget 24.
Kate, help me remember something for everybody's benefit. Manitoba had a project, a guaranteed annual income project, which was reanalyzed very skillfully by Evelyn Forget at the Manitoba Center for Health Policy. And if you haven't read her work, it's probably more than 15 years ago. But
it's about 15 years ago.
Yeah. She went back to look at health beyond the effects of the GAI, Guaranteed Annual Income Program, which was, I think, was an experiment, actually. It had more than one community. And so it's not like it's never been tried in Canada. So I commend that to you. And I mean, if we see, as I hope we will see more of these, the evaluations need to be extremely broad-based, right, as you would know.
Well, and I would submit, I'm forgetting the acronym, but the monies that were allocated by the federal government during COVID. Sorry? Sir? Yeah, this was an incredible opportunity. I hope someone was studying the effects. These are precisely the kinds of questions we need to ask in order to then later say we must act in this way in order to reduce inequities.
Any other questions or comments? Is there anything that I should see online here? Oh, very good. Go ahead.
I am with the Black Health Education Collaborative at the University of Toronto. Hi, Kate. So at IPPH, your commitment really is to advance research, and I think your direction in terms of moving upstream is really exciting for us in the field. What do you see as some of the pitfalls which population and public health researchers tend to fall into when we think about the structural determinants of health?
Thank you, Sume. So, and by the way, Sume was on the team very early on, and I was making reference to her in the discussion we had around, haven't we done this already? The pitfalls. So the pitfalls are covered by a lot of what was discussed yesterday, falling into individual level risk factor kinds of questions. It's very hard for us in public health to think upstream. It demands broader macro level thinking. We're not used to that exactly. It demands much more fulsome interdisciplinary scholarship. So we're quite concerned that we stay within that social determinants intermediary level, and we're trying and we'll work with the community to move them as upstream as possible. So excellent question. Yeah, we're trying to shape the funding opportunities to create that and to help the community move in that direction.
Thank you. We have, I'm just trying to get us to a place where we can see both. We can see questions and you all can see, there we go, we'll try with that. And have us see the questions. And have the audience still see you, Kate, well. Excuse me for that.
It's okay. I can tell you the first question, and it's from Professor Stuart MacLeod, who's been very active in Canadian research and moving into policy for a very long time. His question is, Marmot has argued that a target for useful social policies, social and economic policies to improve health inequalities would be policies that improve social mobility. And I think probably he's talking about particularly intergenerational mobility, which economists and sociologists measure. And having lived in Britain for 16 years, in Scotland, which has the worst health inequalities by social class in all of Western Europe, and very little improvement in them, which is partly why I went there. It's very clear to me that upward social mobility is the exception, not the rule, in the UK. And you might have a comment there. But it certainly appears to me that once people have got their school sorted and they're at the secondary school level, their social class is fixed for life. And it's almost impossible to escape it. But Kate, do you want to comment on that?
Oh, sure. Yeah, with pleasure. So, for those interested in these issues, please read all the work of Thomas Piketty, a very well-known French economist who has studied these issues and shown just massive data to explore how the wealth of past generations creates these inequities, or inequities in wealth over past generations. Again, a demand for more intersectoral work. You said it yourself, John, it starts with the school system. Well, we don't have very much to do with the school system in public health, and we should. Not that school and education is a health issue, but inequities in access to good quality public education does have a massive influence on health inequities. And so we do need to dig deep into not just current income, but past. It's an excellent, excellent comment.
Good, yeah. If you want to, yeah. Oh, is there another question in the audience?
Here, we have a couple here in the Q&A.
Yeah. So I'll do the next one in English, and then you do the one in French. You want to do the one?
I'll do the one in French. Yes.
Do it now.
Donc, la question est, nous connaissons l'importance de la paix et de la sécurité comme déterminants structurels importants pour la santé, mais force est de constater que les pays les plus puissants du monde sont souvent à la base des guerres. Aussi, ils n'apportent pas leur soutien aux pays en proie au terrorisme. Et par exemple la RDC, certains pays de l'Afrique de l'Ouest. Ma question est de savoir quelles stratégies, les stratégies que les professionnels de la promotion de la santé mettent en œuvre pour attirer l'attention des dirigeants sur l'importance d'aider les pays en voie de développement et à assurer leur sécurité, leur propre sécurité. Donc une question qui est très d'actualité. Je vous laisse y répondre.
Oui, excellente question, merci beaucoup. J'avais fait mention des déterminants structuraux et l'importance au niveau global, donc merci pour le commentaire. Écoutez, je pense que si on va être cohérent avec ce que je viens de dire, il faut qu'on soit conscient des effets de nos propres politiques, pas juste à l'intérieur de nos pays, mais sur les autres pays, notre foreign policy. Puis le fait que nos actions ont une influence directe sur la vie des autres. Puis peut-être, pour être un peu cynique, la façon de faire comprendre l'influence de ceci sur nos propres politiciens, c'est de leur dire, si on n'agit pas pour la paix ailleurs, il y aura des vagues d'immigration, des gens qu'on voit actuellement et pour qui on n'a pas les ressources, malheureusement, au Canada, pour bien les accueillir. On le voit aussi avec la pandémie. Si on n'est pas responsable au niveau global, ça va nous affecter aussi. C'est un peu self-serving comme réponse, mais malheureusement, les politiques fonctionnent beaucoup comme ça. Donc, c'est aussi la bonne façon de faire, mais on a à démontrer que si on laisse les guerres continuer en Soudan, au Gaza, partout en Ukraine, il y aura des ramifications aussi ici.
Merci beaucoup, and I'll take a moment to also make a nod to the next session where we will have Professor Reddy who will talk about the global implications of health promotion. So it will tie in nicely to this topic.
Thanks. We have a question from Amanda Sheedy. Thank you for the presentation. Given the long timeline in both the implementation and impact of policy interventions, I'm wondering how you envision short-term research funding as a mechanism to elucidate links between policy and health equity.
Okay, thank you so much.
That's an easy one.
Yeah, thank you, Amanda. Well, we've written this into, we can't say too much, of course, because we as funders can't say too much, but the first Catalyst grant is just the beginning. So that's the short answer. So of course, these Catalyst grants are, 1 to 2 years of funding. There's very little you can do, but you can get going. You can start building your research apparatus and wait for the next wave of funding that will hopefully come down the pipeline. So that's going to be my short answer to the very important question.
It's not easy. It's not easy, is I think fair to say. This is really a comment from Richard Gould. There may be another opportunity to research guaranteed annual income in PEI. It's under discussion there, so we thank you for that, okay. Richard, wherever you are. Yeah.
Excellent.
Oh, is that a comment? Yeah.
I have a question, actually.
Yeah, go for it.
Hi. Thank you so much for the presentation. And I'm Lindsay Richardson. I'm an associate professor in sociology at UBC, but I dabble in public health-oriented research. And one of the questions that I have is really around, we have enormous amounts of data. There's a gigantic body of work around social determinants that is predominantly descriptive of how inequities are produced. And I'm so thrilled to see a call for structural determinants-oriented work at IPPH. And my question is, how do we make sure that the research that we're doing is less focused on the what that we already know and more focused on the how? Like, how do we actually do these things in practice and in real life? Because researchers have demonstrated extraordinary capacity for describing the what and less capacity for that more visioning process of the how.
Thank you for that excellent question, and I'd invite you to come and have coffee with our team. We're right here in Montreal. This is very much what we're trying to do. We're trying to structure our funding opportunity to move the community in that way. We will be running online webinars to have these discussions, and it will be the job of all of us to figure out how we do the how. So I invite all of you interested in this. $4 million is quite a big investment. Apply with your postdocs, your students, your senior career, early career. This is a work in progress together to figure out how. And then my job is to move that to the policy level.
We have a question online from Karen. People have been living without health, food, housing, etc. since the colonization. Is anti-oppression work to dismantle these structures and systems being considered?
100%. Yep, it's written right into our FO. So yes, absolutely. So that may respond a little bit to Gaynor's question at the beginning, but absolutely. Yeah, that's my answer.
Okay. Question over here?
Sorry.
Go for it. Yeah.
Allô? Ok. Bonjour, je vais parler en français. Mon nom est Carole Mathieu-Ndem du réseau francophone international de promotion de la santé. Merci beaucoup pour la brillante présentation. Ma question est de savoir si, selon vous, il y aurait plus d'efforts à faire en matière de vulgarisation des déterminants structurels, mais auprès du public général, de la population. Parce qu'on en parle beaucoup, mais si on veut vraiment que ça change, peut-être il est temps expliquer d'autres personnes, en fait le public général, pour que tout un chacun comprenne en fait quel est le lien entre sa santé et puis comment est-ce que la société est organisée. Merci.
Excellente question, Carole. Je suis ravie. Carole est une ancienne étudiante à moi, donc c'est ravie de voir demander une telle bonne question. Écoutez, on le travaille. C'est vraiment, puis mon équipe l'entend, là. C'est sûr que même les déterminants sociaux de la santé est difficile à comprendre. Puis, moi, je le travaille même à l'intérieur des IRSC parce qu'il faut comprendre, on est 13 instituts. Et dans ces 13 instituts, il y a des cardiologues, il y a des infectiologues, il y a des gens que, pour eux, les déterminants sociaux de la santé, c'est vraiment un autre langage. Donc, on le travaille, puis on le travaille spécifiquement avec des exemples. Des exemples concrets fonctionnent très, très bien pour faire comprendre l'influence, l'importance de ces problématiques-là. Ça fait partie de notre call de Catalyst Grant pour voir qu'est-ce qui rentre comme exemple concret d'examination de ces déterminants structuraux. Mais ça aussi, ça va être un work in progress. Il n'y a pas eu, même si ce cadre existe depuis 2010, il n'y a pas eu un travail cohérent autour de ça. Puis, je dois avouer, dans mes propres cours, j'enseigne ce cadre-là. Depuis des années, je dis « Ah, ben cette partie-là, c'est faite par les gens en sciences humaines. Nous autres, on ne touche pas. » Donc, on bouge dans un autre realm. Merci.
A question over here? Yes, in the black.
Good morning. Hang into my dishes here. My name is Claire Bedker, and I'm the Scientific Director for the National Collaborating Center for Determinants of Health. My question is a little bit of a feed forward, but before I do, congratulations, Kate, on your appointment. Great choice, and look really forward to working with you in collaboration, close partnership, and also on your bold vision here, which I'm going to call leadership. So my question, and I think it's mostly to the audience, but also to you, what is that leadership? So yeah, we'll figure out the how. I mean, I think you're going to make a contribution there, and you're going to get those answers. And, you know, Evelyn Forget's work on what occurred in Dauphin, Manitoba, but there's also some other excellent work in Manitoba that shows an income supplement has huge impact. And actually, I think it's been doubled in Manitoba just in the last couple of months for pregnant women in Manitoba. But it took leadership, right? It took influence, it took persuasion, it took effort to bend that political will or influence that political will. So my question to the audience, and that's what I heard yesterday and I'm hearing again today, what is that leadership? And how do we collectively start to groom it, keep that courage, that boldness in each of us as we move forward on what's not going to be an easy path? So do you have any comment about how you would build around those catalyst grants, that collaboration, community of practice, networks, whatever we might want to name them, where we can collectively support each other in that leadership as we move forward?
Thank you for that excellent and very thoughtful comment. And I'll attempt an answer and then I'll turn it over to others. So a number of thoughts, Claire. First of all, we have purposely attempted, there is some pushback from CIHR, to have non-researchers be principal investigators for these Catalyst grants. Yeah. So we are, and I'm hawking this publicly as the possibility for public institutions, NGOs to apply for these kinds of grants in association with researchers, but to really to have that cross-intersectoral work that is going to be necessary to get this work done. This is not just the work of researchers, obviously. That's the first thing. The second thing is we tend to have this notion, even I do, that this work is only at the federal level. And it's not. And that's why I purposely wrote, it's in our everyday. It's in the municipal. Look at this brilliant presentation that Dr. Drouin gave yesterday about the effect that the Direction Régionale de Santé Publique in Montreal is having with their broad thinking. They make significant change to the lives of Montreal citizens. And we need to learn at these different levels about how they're doing their work, how we can take inspiration from their work, how we can better work together. These are ways that we can work more cross levels and intersectorally in much more, so not even interdisciplinarily, but intersectorally in more fulsome ways. So I'll turn it over to the rest of the panel, actually. Or the room.
I couldn't improve on that.
Yeah, me neither. I just wanted to point out to what you said to Montreal. I think looking at those where it's getting done, essentially, right? This is where the rubber hits the road, and but bearing in mind too that Montreal is, I don't know exactly what the population is that they consider their population, but of course it's a porous population or a porous boundary situation, but it's at least 2 to 4 million people, which is larger than some provinces, many provinces. So there is scale and there is capacity there too, but I think that's the important point also of, to move beyond the land of pilot projects. How do we scale up, roll out, and make sure that we learn from each other? And that has been a perennial challenge with our multi levels and our different divisions of powers, I think, is where I'll leave it.
Yes. There's a question over here, Madam.
I'm an assistant professor at McGill University in the Department of Medicine. Thank you so much, Kate, for this wonderful presentation. Hello. I really enjoyed sort of the broad view that you took and the history of what we've learned about social determinants of health over the past few decades. And my question is, if there's capacity within the vision of the IPPH to collaborate with and learn from researchers doing this work in the Global South and in other parts of the world. And because I noticed there was a framing of the Canadian context, which I completely understand, but I'm curious to see if there's been conversations around that and what your thoughts are. Thank you.
Excellent question, as always, Marilyn. So great to see you, Dr. Owen. Yes, of course. So the way we've written it, the funding opportunity, it is not only for researchers working in the Global North. So we could have, and we will accept applications for people looking to understand either the situation in the Global South, learnings from the Global South, or even comparative work, Global South between Global South countries or Global South, Global North. And I'd say even more than this, Marilyn, we have, if you look at our strategic plan at IPPH, one of our other strategic initiatives is global public health. And my team is working very hard to have us cross-fertilize across the different initiatives. So there are possibilities there as well to have perhaps some back and forthing between the different initiatives. But 100%, yeah, this is not just a Canada-focused. We would hope that it wouldn't be.
I'll just mention a really major obstacle to lower income country researchers participating fully in these sorts of calls. I just spent 3 or 4 weeks working closely with 2 Tanzanian colleagues, a country I worked and lived in, and to put in a grant to a British funder, NIHR, the national NIHS funder, to the Global Health Development Research Grants competition. It was due today. It was impossible for them to get the local administrative support to fill out the 30 pages of forms about administrative issues, financial issues, management issues, risk registries, flow diagrams, all of which is a way of, I think, maybe not deliberately, but effectively barring people from those environments from being co-applicants on a grant, and certainly lead applicants, as is the case here. So, we have a long way to go. I know Kate will keep her eye on that, because that's one of the bureaucratic problems. Yes, Madhu.
Mic on. Madhu Pai, I'm the chair of Global and Public Health here at McGill. In the area of global health, which Professor Reddy will cover soon, we have a very similar struggle. I mean, we have mountains of data on the inequities, and yet we are not able to do much about it. Case in point being, we all saw the unfolding train wreck of the COVID vaccine inequity, and we couldn't do a thing about it beyond publishing op-eds in Lancet and whatnot. And that example of especially seeing India collapse spectacularly with the Delta variant, where 3 million Indians died in 3 months, woke me up to the reality of how we have to get political if we have any hope of addressing anything we're talking about. And that's what led me to speak in the parliament, go and meet community organizers, become an activist, so to speak. But then I realized that for many of us in the room, we are addressing this at a very intellectual level. The struggle is really not at the grassroots level. Our disconnect from organizers, our disconnect from the true activists and advocates on the ground, makes us stop at the intellectual level because it's terrifying to get political. Right now, I think we can all agree, students in North America are showing us what it means to go beyond the intellect to actually organize. And we as academics are absolutely paralyzed with our inability to get political or to organize ourselves in a manner that can actually influence politicians and change anything that we're talking about. And I don't have an answer, but I'm struggling with it as much as every one of you in this realm are.
Thank you so much for that very, very thoughtful comment. I would encourage you to go back to the Ottawa Charter for health promotion. Advocate, mediate, it was all there. Equitable health promotion, and we haven't spent enough time talking about the critical aspect to health promotion, which is that advocacy, political side that's absent from a lot of the more descriptive public health that many of us do, which is incredibly important, but that tends to be flattened politically a little bit. So there is work that is being done in this area, and this particular call at CIHR will help potentially create more movement in this direction. Yeah, thank you.
Madam in the black dress, I've missed you, I think.
Oh, no, it's okay. It was just an add-on to say that, so my name is Pema Mazumdar. I work with the National Collaborating Center for Determinants of Health, NCCDH. And I just wanted to add a little bit that, so as people in the audience have been asking about methods for thinking about getting political, redistributing, what I would call redistributing power for getting to that health equity place. Yeah, absolutely, Kate, go back to the Ottawa Charter. We have been coming out with quite a few, this is a resources plug, but we have been coming out with quite a few pieces. Most recently, a Public Health Speaks on community organizing and what that means to become more involved with and better relationship with, work with community organizers when one feels that the power is not there individually to organize oneself. So just to say that check out that our website. It's nccdh.ca if you want more of that kind of stuff, and you'll be seeing more from IPPH as well as we continue that partnership.
Thank you. Well, I'm sure because there are more questions online, I apologize to those who we couldn't get to the questions of, but I hope they'll be recorded somewhere. And so I want to thank our speaker and all of you. It was a great discussion. And I'm going to turn it over now to Amélie to close this session.
Thank you so much. There's never enough applaud. We can always just keep going. I did want to kind of maybe to close this last question, I think one, to bring back an image that was shared to us yesterday, the elephant. One of the elephants in the rooms when we're talking about, the point that Madhu made and that many of us have made is, it has to do with how academic work is rewarded, right? And what we have been producing, what we have been taught to be producing, And I want to say also that I think that the tides are changing ever so slowly. This is not a tsunami, but for those of you who are also at the beginning of your careers, it is increasingly being recognized, notably through the Declaration on Research Assessment, the DORA, that our university has signed on, that CIHR has signed on to. Hopefully your universities and organizations and you yourselves can sign on to, recognizing that impact in research takes different forms, especially when it is community-based and when it is participatory. And that is slowly making its way into peer review committees, into the thinking, into our dossiers, and being recognized as such. And I think that is also something that needed to be put in place, needed to be understood and promoted, and it's getting there. It's not done for sure, but yeah, so that a little bit of a word of hope, also of what are the conditions to make things work? Well, what will it take? This is part of what it does take in order for these collaborations to work both ways. So on that, I will end by thanking our moderator and our panelists. I think, again, we are setting the stage for the rich discussions that will happen today. I'm very much looking forward to those, and I invite you to take a small break and join us back at the next session to hear about wicked problems and emerging issues. Thank you very much, everybody.